So again, parts therapy is the focus for today, but it's all the same elements are involved with practically everything we're teaching. So Eric has, again, from a whole different angle, what is the first thing that you were going to present today, Dr. Rosen?
About DSM.
Very good.
And then talking a little bit about MS.
Perfect.
Okay. About the last, about what you were just presenting, I don't know if this is here or not, or if we'll cover it. So if it's the wrong question, just let me know.
Sure.
I am interested in learning about different types of personalities for cancer. And again, my training, everything was called differently. So I don't know. Would this be the appropriate, is that parts?
Did you say with cancer? I missed part of it.
Yes, ma'am. So the different, you know how different cancers have different personalities, you know, in the research, would that be a type of parts therapy or something different?
My answer would be, it could be, and to really get into that would be more like a specialty training in working with oncology, which I would love to develop a whole program just for that. Again, each one of these pieces is condensed, and then you can take it to just unbelievable layers of levels above that. But I'm sure the things that we're going to be talking about and doing with the parts and the different pieces I'll give you will spark your own creative juices to realize what you might be able to do with that.
It would be a parts therapy thing, what I'm asking about. Is that right?
The idea, I think, behind parts is that if we conceptualize, not only do we wear different hats, but what happens if we have different intentions, or we have different aspects of who we are and what we're experiencing. And then what happens, I believe, is that they can be in conflict. I think the point about parts therapy is that there's a tension or a conflict between different sides of yourself. So your idea of, might there be a way to use parts for different kinds of cancers, I would think that if somebody conceptualized their cancer as, which is being done, almost objectifying it, so that you see it as a part of you, but not all of you. In other words, you have cancer, you aren't cancer. You know, you have a bipolar illness, you are not bipolar. You have schizophrenia, you're not your whole person is not made up of whatever this part is. So tell me your thoughts, Christy, about the different kinds of cancer and how you might want to use this idea. And then that'll help clarify for me how I might see it being used.
Okay, so I'm looking for the clarity too. I know for sure that different personalities, well, different cancers, or let's see, so breast cancer, usually people who are diagnosed with breast cancer, I have very limited knowledge of this, by the way, not cancer, but this part, which I'm trying to think about and kind of move into this space. But people with breast cancer usually are the people-pleasing type. You know, they have that certain type of personality, or campaigner per se. So I was thinking, well, I wonder if that is really what parts therapy is. Should I take more training in parts therapy to be able to think about that, research that, you know, or is that just a totally separate, you know?
Well, I definitely like the idea of more training in parts therapy, because then it gives you the foundation to consider how might you address that part. But again, because parts therapy is really exposing two intentions, two forces, two dynamics that are in conflict, that leaves the person almost immobilized or ambivalent or stuck. In other words, someone that says, I want to stop smoking, but I can't. Someone that wants to stop eating bags of potato chips, but they can't. They want to be healthy, but they're not engaging in healthy behavior. So when we have these tension points, then parts therapy lets both these parts that are almost in polarity kind of negotiate with each other to see that they're serving the larger good of the whole person. Because, see, I think in parts, what happens is when we have a conflict in ourselves because we want to do something but we're blocked, we're just not following through, we're not engaging it, we don't feel we have the willpower, then what ends up happening is we want to get rid of the part that isn't working. But the whole dynamic, the whole foundation of parts therapy is you cannot get rid of parts. They're part of all of us. So it's the holism that we might have some parts that are working against us, but I would have to say that there's maybe even a conceptual understanding of parts that even the parts that we might think are bad might be fulfilling a need. And fulfilling that need, it, according to the part, it may be, hey, that's their purpose. Their purpose is you're going to eat bags of potato chips. Now, you might say, well, what's good about eating bags of potato chips? High cholesterol, you're going to put on calories, you're not going to feel good. But what happens, and this happens in parts therapy, where somebody, that part that they may label and give more dimension to, could be, well, when you eat those bags of potato chips, you're finally sitting down and relaxing. And you don't relax enough. You really work too hard. So I'm helping you to relax. And that could come out in parts therapy. So I imagine with cancer, the idea that breast cancer, from what I'm hearing you say, may be more assigned to someone who is a people pleaser, then might, in exposing that part, and maybe the polarity would be the healthy part, someone that wants to feel better and not have to deal with the illness, then maybe that part might be saying, well, it could be exposed. I'm here, even in cancer, because you work so hard at pleasing people. So this gives you a chance to focus on yourself. That could come out in parts therapy.
Yeah.
But we can't, again, I know it sounds almost like an oxymoron. Okay, you're not going to get rid of cancer. The hope is that the body and the immune system and even the conventional medications, the oncology medications, will eradicate it. But it's possible, from what you're saying, might the people-pleasing parts still be there even after the cancer is gone?
Exactly.
Yeah.
So do you think
And the only thing,
the best technique to try to explore that?
and the only thing I would add is that you want to be very careful not to, it's great to study, that I know there's certain conditions and diseases that they connect to certain types of personalities, and those are great research, those are great books, and they're based on a lot of valid information. And yet to have that, but not to go in with that preconceived idea, and I know that's not what you're saying, but like Eric said, if it shows up in the session, it can help you, just like with the DSM that Eric's going to talk about, it can help you to know what questions to ask, knowing that a lot of people with this problem that may not come up on its own. You can ask the question, and without leading too much, of course, and to have that person answer those questions. And then it could be, like you said, that people pleaser, if in your determination is something that is an aspect of something that's interfering with them healing as well as possible, then you could bring that up in a parts therapy type session. Again, the answers to the questions should guide the session.
Sure.
Of what comes from the client, and the more emotion connected to the answer, to me, the higher the priority. You want to address that in the session sooner rather than later. Does that make sense?
Yes. And in both of y'all's experience, do you think this would be, again, I'm not holding you to anything, not that this is the end all be all, but would this be the correct approach to take? The technique is amazing. Do you think, since cancer is really physical at this point, do you think this would be the correct approach? I just want to train in the right thing first, is what
I think parts is perfect for physical conditions. Absolutely. Because again, we're not going to say there's a part of you causing cancer. We're not going to say that to the client. We're going to find out what's the emotional connection and find out there's a part of them that is wanting to be whole and healthy and working toward healing. And there's another part of them that is that part that is not processing this, you know, part of the body or the cells in that part of the body in a way that's most efficient for the perfect blueprint we talk about, that's at the unconscious level. And to find out what is interfering, what is it that's keeping that person from healing. Now to me, we hold in us that maybe that part is the part that may have, you know, there may be an ultimate cause, because in studies of cancer, as you know, they usually, years ago, they found out that usually about 18 months before cancer shows up, there's some crisis in that person's family. And that is pretty much universally almost always the case. Or there's a series of things sometimes that lead up to it. So again, if you don't get to that core, if you don't get to that ultimate where it actually the seeds were planted or started, that thing that ended up, you know, causing the malfunction in our mind to allow that cancer to be created in the body, to take hold, if you will, then it's going to come back. How many people have been turned clear of cancer? Paul Durbin comes to mind. I got an email still on, I refused to delete it. Paul Durbin had liver cancer, and he sent me an email and said, I just got the doctor's report and it is clear. I'm 100% free from cancer. He was dead like 3 weeks later. It came back. So the idea with hypnosis is we're going to get back to whatever caused it. Like Eric said, if that part still isn't getting its need met, the part that originally created it, in our mind, like, again, we're not going to tell them they created their cancer, but in our mind, if we can get to what started this malfunction in the system that allowed that to be created, it's going to be an emotional something trigger. And if we can get to the source, the original source, that cancer isn't going to come back, because once that's cleared, that need has been met, which we do in parts so nicely, and it can be done in a very simple way. Get that need met in a healthy way. Now that doesn't need to be there anymore, and it won't come back as long as that need is being met in a healthy way, is the whole idea. I think Nicholas had something you wanted to add. Can you still remember what it was? It's been a while.
I think this cancer personality is not related to the parts therapy. For me, it sounds like more about thinking patterns. If you have this kind of thinking pattern, that if it gets wild and malicious, it can develop this kind of problem. If you have the thinking pattern of wanting to please everyone and it gets out of control, then it can cause breast cancer problems. So I think it is about thinking patterns. Sure.
Yeah, but the thinking patterns, yeah. And that's what we call the part that thinks like that, yeah. That has that compulsion, if you will, to please everybody. If that's part of the source of the cancer, then parts can help with that. You don't think so, Nicholas?
Yes. In this case, yes. Yeah.
Okay.
It's just,
I know.
Yeah, I think it's clear. Yeah, okay. I agree.
Eric, go ahead, Eric. We need.
I was just going to say, I know we all, the fact that we have an interest in wanting to help people through harnessing their strengths. I think that's a foundation that ties us all together as helpers. At the same time, I also see some scope of practice issues that we have to be mindful of, which is that while I do believe there is a mind-body-spirit connection here in terms of illness and health psychology, we don't want to also promise that we can relieve them of cancer.
All right.
In other words, we can't say, and then there's a flip side. Empowering someone to see that possibly there's a part of them, and we have to bring in the psychobiological environmental parts, the epigenetics of cancer, which is, the foods people eat, the toxins they're exposed to, the stresses in their lives. I mean, there's a whole fabric here, and I'm not an oncologist. I know enough what I don't know, but I also understand that what they're discovering in the field of cancer is that everybody has cancerous cells. and that really it has to do with different proteins turning off and on in our immune system being able to fight it. And so there's definitely a biological genomic template that can even run in families, and it doesn't mean someone caused their cancer. My concern is that empowering someone has a flip side of, well, if I can fight it, that means maybe I did something that caused it, and if I can't get rid of it, oh my gosh, then that means I'm bad. That means I did something wrong. People with illness, this whole health psychology aspect of the meaning we give to illness is a powerful thread, but it also contributes to feeling totally helpless and disempowered, and that leads to depression, and that diminishes our immune system. So you can see how it's connected here. So at the same time, I definitely can see using hypnosis, parts therapy to empower people. It's not creating expectations that are reasonable so that we don't come across as looking like mystics. I mean, because we're dealing with people with the science of a medical issue. And at the same time, it is fair to say, you know, there is research that does suggest that the ability to be empowered, that you have some influence, and maybe we can make use of that. Now, if it doesn't work and they end up with stage 4 cancer and they're looking at terminal cancer and we use the hypnosis, what I wouldn't want is for them to internalize that as either we failed or they failed.
Right.
Does that kind of make sense?
Yes, I actually do volunteer group sessions at the American Cancer Society when I first started a couple of years back because this is what I wanted to get into. And I always, what I have come across is that you can't break through anything until you break through the fear, no matter what. And stress and immunity is actually the biggest thing. It's where you start, where I start, even people in treatment, and they feel better right away. So of course I never say, oh, you know, we can cure your cancer. I don't say cure or heal. I say help, you know, anyway. So I definitely totally agree with you, Dr. Rosen. Thank you so much. I appreciate that. And also, in case anybody cares about this, I would like to say in my own training, only 15% of disease is genetic. And we've been doing gene testing probably for the last 4 to 5 years in my office. And I have had 2 people come back with breast cancer gene, just 2. And we see hundreds of people. So it's important to know that it really is epigenetics. It really is environment, and has a lot to do externally, you know, as well as internally. But it is important to note that genetics plays a very, very, very small factor now. We know that now because of recent research. Well, 100 years research, but you know what I mean. And
it you know, but it seems like the more conveniences we have, you know, and we learn all the time of, I mean, I just was listening to NPR the other day, and they were talking about how that in a lot of our furniture, even our mattresses, our couches, our chairs, that some of the flame retardant chemicals that they put in many of the fabrics that has been there for years now, it's carcinogenic, you know? So, I mean, let alone food. So understandably, this is a very multi-layered issue. And so I love the idea to help create relief and hope, and the possibility that through hypnosis, people can address fears, which can be very powerful.
Yes.
I work with a couple people that are with cancer. Understandably, there's different entry points where they might come in to see us. It could be having discovered it. It could be that they're getting oncology treatments and they would like our help to manage some of the side effects, because hypnosis could help with the side effects of cancer treatments, the nausea and the headaches and the fatigue. And so we could make use of either creating some relief with some of those symptoms. It could also be, I think, you hear the word cancer and you can't help but start to think of mortality,
That's right.
which means we're also dealing with the fear of what's next, and and how much time do I have?
Mm-hmm.
Yeah.
And is it away forever? And, oh, I got a clear, you know, what I deal with most is, oh, I have a clear mammogram or whatever, a clear scan, but they still cannot be comfortable after that. You literally live in fear almost for the rest of your life. And that kind of has the ripple effect to the families too.
Yeah. And there's another thing that we can help with hypnosis is to have to change lifestyle, because it's essential for cancer patients as well. Eat healthy, maybe change those furnitures, and with hypnosis we can help them to be able to achieve it.
For sure.
Yeah.
Thank y'all for addressing that. I really appreciate it.
Eric, you gonna do
Yeah.
move on to the DSM?
If you can enable the screen sharing for me.
Yeah. Screen share. Okay, that should do it.
Alrighty. Patty and I, I always learn new things and get to expand my creative thinking in conversation with Patty, and that's and it's interesting. We both have the same goals, and yet our paths have been somewhat different. So, coming from the license side of making use of hypnotherapy, as opposed to the certified side, is that I end up having to consider diagnoses. In fact, part of my professional responsibility if someone comes to me, and believe it or not, also to get paid, is that I need to be able to assign a diagnosis, and then that drives what would be called a treatment plan. On the certified side, it can be helpful to think of what we're doing as a kind of method, a kind of helping plan, if you will. In conversations with Patty, when we first started these conversations and working together, I know the orientation, it's almost like our fields have been almost in competition and in kind of a polar conflict, which is do things holistically, empowering the individual, look at the person's internal strengths, and then the other side, the medical side, has been that it's been more something you do to somebody, you make use of a diagnosis, it kind of conceptualizes what the disease process is, if you will, and what do you do with it. I will say that there has been a movement and almost like a paradigm shift in how we can consider people's issues. What we're starting to see more and more, even in the medical area, is the idea of a collaboration, a relationship, where, and many physicians, if you've been to see a physician who might make use of this, is they may use motivational interviewing questions that help you to look at your part in it, to empower you to become a participant in your own wellness. And so in Patty and our conversation, what came out of it was, is it possible that because people will come in to see us, whether you're certified and or licensed, and they will reference different diagnoses they have. I love when Patty talks about, you know, you aren't your diagnosis. And I agree with that 100%. It's a facet of what people are dealing with. So in our conversations, where we've kind of moved together on is there's value to understanding what people might tell you. In other words, if they came in and said, yeah, I've been diagnosed. I have depression. Patty has a great question. So tell me how do you know this? How has this come to you? And they would say, well, my doctor diagnosed me, or a psychiatrist diagnosed me, or a therapist, or there are times where people say, well, I've been on the internet and I looked it up. I know I have that, you know? And so I will tell you, I see the value of a diagnosis only as an opportunity to better understand what someone's dealing with. And there are some evidence-based approaches in the medical realm that then tell you how might we treat or get better using conventional medical approaches. I do believe you're not your diagnosis. I think we're much larger than that. I think the diagnosis can be only helpful if it's assigned accurately and if the person has understanding of what it means. And then what can you do with it? So isn't it interesting with hypnosis, we're helping people to see their part in taking care of themselves. That's what this is about. So in our conversations, Patty and I, we've arrived that is it possible then to understand something about how diagnoses are assigned. So when people come in and they throw the labels at us, if you're licensed, you will be having to work with the diagnosis, maybe even assign a diagnosis. If you're certified hypnotherapist, then understanding what they come in with can help you, in the terms that Patty and I have come up with, is to unpack the diagnosis. In other words, try to figure out, well, what is it about the diagnosis that then helps me as a hypnotherapist to create, I call them hypnotic targets. Where are some of the places, and I can ask more questions. Tell me about, how do you experience this? What is that like for you? And then understanding the different ways it affects their life, and then put on the hypnotherapy hat, which is, are there some hypnotherapy techniques that then we can deliver, can bring into their experience that help them to create symptom relief, to create more calm, more relaxation, more hope. If there's pain issues, create more somatic relief, physical relief in their body. So if they have sleeping issues that are part of anxiety or depression or pain, can we help? Because sleep is a subconscious, unconscious process. So it's a perfect area for us to apply hypnosis to help people to get rest. So I believe knowing a little bit more about what their diagnosis is, if they come in and tell you this, means I'm going to have more awareness now to know where I can apply hypnosis. And so this is not in any way to make you an expert on how to diagnose if you're not a licensed person. It's really to give you, now I look at it this way, knowledge is power. So having more understanding about what someone's experience is and the questions I might ask. So that's what this is really leading into. So the purpose of this presentation is some of the reasons why someone who is a certified hypnotherapist can benefit in understanding a little bit more about diagnoses. If you are already licensed and you're making use, then I believe it's compatible then to look at, well, how might I make use of understanding the diagnosis if you have a licensed background, and where the hypnosis can be plugged in. And there's a bridge here. I really believe the certified hypnotherapists and the licensed clinicians, there is a common ground that helps you to work with people that are licensed who may not do hypnosis, and you can then make a use of this as a marketing tool that you can work in a complementary fashion, in no way competing with their medical treatment, but help to create possible symptom relief, meaning that they could feel better, they could sleep better, they could have less discomfort. If they're getting medical treatments that do have side effects, might the hypnosis help to mitigate some of the disruptive aspects that make people feel worse. And so part of this also looks at the hypnotherapist's role. We're going to talk a little bit about the origins of the DSM stands for, and it's now this big purple book. It's the Diagnostic and Statistical Manual. We're on number 5, so it's the 5th edition. It just came out about 2-3 years ago. We're going to talk a little bit about this new approach, because there's some novel things about it that are very cool. And by the end of the presentation, you'll understand when I say it looks cool, it's because it's a little more holistic, and it's a little bit more understanding about the influence of culture and diagnoses. Also, we'll talk a little bit about professional boundaries when working with people with different diagnoses and what they come in with. Patty talks about seeing outside the label box, which is that way of saying that we don't want people to think of themselves that in their totality, they are the illness. They're just a walking medical illness. And I will tell you, the meaning of that oftentimes is brokenness, is damage. And if somebody feels damaged and broken, then it can lead us to feeling disempowered. We lose a sense of mastery. We feel we can't do anything. So there's a quality, we call it learned helplessness, which means I can't do anything. It's just going to keep on happening to me. I would also suggest to you that that meaning of feeling broken, damaged, can lead to people not feeling loved, that they're not worthwhile, who's going to want me, the feeling, and then if it starts, their illness starts to affect work, and work can be a strong part of people's identity, and so what happens is then they feel incompetent, inadequate, disinclined. They can feel like a failure. So all this gets subsumed if people get totally consumed by having the diagnosis. And sometimes it's also what the diagnosis may do to them if it's not treated. We'll also talk about reframing the client's situation, and then talk about some case studies using DSM and how do we create hypnotherapy well-formed outcomes. So some of the reasons why I think it's helpful, even for non-diagnosing clinicians, to understand something about diagnoses, is that it can, again, I will tell you that when I work with physicians, and they start getting into the gobbledygook of anatomy and physiology and so forth, and biochemistry and organic chemistry, I will tell you, as a psychologist, I am familiar, that is not my scope of practice. So if people start to, I'll share a funny story. Years and years and years ago, we had a golden retriever, and the golden retriever ended up with a gastro problem, had to rush him to the vet, and even the veterinarian then called me up and heard on my tape, it said Dr. Rosen, starts going through every physiological anatomy part of what the dog was dealing with. I had to go, whoa, can you talk English, please? Because I don't have that background. So I would say that this doesn't mean you're going to start having that kind of conversation about different diagnoses and the nuances of it and how it was diagnosed. What we're really talking is having kind of a global picture, so that if someone comes in to see you and you're talking with someone, I understand someone's coming in to see, this person's coming in to see me, they signed a release, they're dealing with a panic disorder. And today we're going to talk about that. What's the difference between anxiety and a panic disorder? And now you having some understanding by the end of this, you'll be able to have a little bit of that conversation. In other words, I could help them with some of the symptoms that happen with a panic disorder, and helping them to relax more, to get more in the moment, to be a little bit more mindful, to create, possibly to even go to sources for panic. And oftentimes I'll share this with you. Panic disorders are a close cousin to phobias. In other words, sometimes somebody can start with a panic attack driving over a bridge, and then that turns into a phobia, meaning now they're afraid to go over bridges. And so hypnosis is beautiful because we can go to the source for maybe that initial sensitizing event where they went over the bridge that one day and the traffic really slowed down, and they looked over and saw how high they were, and so now all of a sudden now they start to not only have the symptoms, which can be rapid heartbeat, shallow breathing, thoughts of doom and gloom, feeling like you're going to pass out, and oh, I'm not going over that bridge. And the thing about phobias is that it's kind of like ink on a silk blouse. Once just a drop just spreads. So someone starts by having that sense of discomfort, breathing, anxiety, starting to overthink. They go over the bridge, and then by the time they're off the bridge, or they might even stop on the bridge, I am never going over a bridge again. So what do? They not only start to stay away from bridges, but they might take alternative routes. I've worked with people in the Tampa Bay area. We have a whole bunch of bridges, and what can happen is they will drive literally an hour out of the way to get to their point so they don't have to go over bridges. You can get to a point where they don't want to get in their car, and there's an example of how it just kind of spreads. So having this understanding means you're going to be more mindful of some of the hypnotic targets and maybe the questions to ask. So if someone sends them to you and you call them up with the consent and you say, yeah, they came to see me because they have a fear of driving over bridges, then might it be, you know, as your physician, or maybe you're talking to the licensed therapist or psychologist and say, you know, I'm just curious, are they also dealing with panic attacks with this? And is it leading to avoiding other types of situations? Because hypnosis can help with that. The other issue can be that issue of trauma that we talked about last time. Might some of this happen out of a trauma origin? And that can be a question, you know, for the clinician or the physician. So I'm helping someone with a panic disorder. Have you seen any other origins for trauma that might I could be a help with? Because it's not uncommon for panic disorder even, or certain phobias to have origins that may come out of trauma. So again, you're not diagnosing it, but just having that mindful question, wow, you might learn something that maybe, and I will tell you this, the clients or patients that we see don't always tell us everything. You know, and so sometimes we can find out after we're working with them, wow, I didn't know that. Another reason can be promoting the clinical conversations like we're talking about with other referrals, the referring clinicians, the physicians. The other is, I believe, if someone comes in and there's a diagnosis that they're sharing with you, and it's not I don't think it's an unfair question. You know, have you worked with a physician or a licensed mental health clinician around the issue you're coming in for? Okay. Have they, and I would word it this way, you know, it's not uncommon where medical providers and even licensed mental health therapists may also assign and deal with different diagnoses. Have you has any of these clinicians talked with you about any diagnoses that they may be working with you on or have worked with you on? Again, notice the wording, things that have come up that they've been helping you with, as opposed to, so tell me, are you a bipolar? See, we're not doing that. We're basically just wanting to know, are there any diagnoses that your physicians or other clinicians have worked with you with? And again, we're going to be seeing how we can take this and translate it into hypnotherapy targets, if you will. So the role then can be, well, let's get back here, supporting the referring clinician In other words, they're another member of the outpatient, basically people's healthcare plan team, if you will. In clinical circles, it would be an outpatient treatment team. But you become part of that team in terms of helping people when someone comes to see you. One of the things that we've arrived at, because when Patty and I first started these conversations, I recall that the strong press to be holistic has made it difficult to accept the whole construct of diagnosis, because I will tell you, diagnosis, it has some downsides. The downsides are it's kind of reductionistic. So what it does is it means you are a part, this part is all of you, and I don't believe that. It also creates limits in thinking, like I'll never get better, I'm damaged, I'm broken, I'm always going to have this. Some of the other downsides is that people feel a hopelessness with a diagnosis. They see conventional medications as weakness, and that they're also that they're dependent on the medication. And these are all reasonable things that people feel. Hypnosis can help people to also, and parts therapy might do this. How do you come to terms with, as we get older, any of us can have other medical issues that surface that you didn't create. It's not necessarily your fault. It isn't your fault. It's just what our mind body does. And so sometimes we may have some medical issues that we need to be able to, we may not like it, but if we can find a way to live with it and live with it to still have the best life we can, that's a different reframe than to live with something that I don't want, that's taking things away, and then it feels like I'm in battle every single day. And if it becomes a different reframe for the person, might they then, and this is, I know this is a huge reframe, is it possible when people have medical issues that it helps them to pay attention to being healthier? In other words, sometimes people may not have medical issues. They are not acting and taking care of themselves in the most healthy way. They get a medical issue and the medical issue. And I'm not saying it's comfortable, pleasing, or something anybody would want to say, boy, I hope you can get this. But there is a reframe here. And the reframe is, you know, isn't it interesting that sometimes things that we struggle with and we're challenged by actually can help us to have a better quality of life because we're bringing more mindfulness to doing healthy things. And that's almost like befriending what it is that we don't want. It's very hard to conceptualize that, but I see it as a huge reframe. And I also see it happening for people, is that when they come to a place of acceptance, then they start to find ways to help themselves feel better, to be healthier. They still can live with diabetes, but if they're walking regularly and eating better and checking their blood sugar and making use of their oral medications or insulin, and then they can say, you know, I am healthier now than I was 5 years ago. That would be huge, as opposed to, no, I have diabetes and I still want to have those Big Macs and chocolate cakes. And yeah, I don't think I'm going to check my blood sugar. It's been years. It's like, and then, oh my gosh, I can't feel my feet anymore. And they come to us and it's like, so how would you like me to help you? Well, I sure don't want this diabetes. Can you get rid of it? Again, all the different ways that I suggested, we may be able to help with the being able to mobilize better self-care and then to feel better about their empowerment to do that. Now, interesting enough, talk about diagnoses. There's a high correlation between diabetes and depression, and it's an inverse relationship. Years ago, you know, Bayer aspirin, it's a, the Bayer company actually contacted me. It was a group of frontline responders, and they invited me to a luncheon at in Tampa And I did a PowerPoint, and it was all about diabetes and depression. And the fact that people that, and what I mean by inverse relationship is that if people are depressed, they can have a likelihood to become diabetic if they have certain factors operating, like heart issues and being overweight, and if there's genetic factors like diabetes has run in the family and so forth. But it works the other way. If you get diabetes, there's a high likelihood you may end up dealing with depression. So if, you know, someone comes in to see us, again, this mindfulness is not projecting and assuming that someone has something. It's just a question. You know, the question could be, someone comes in, yeah, my doctor sent me to you because I have diabetes, and it's been, you know, the blood glucose has been like 400 and 500. They can't get under control. And, you know, I don't want to go blind. I don't want to lose my limbs. And my doctor thought maybe you could help me so I can, you know, get on top of this. And so then it would, you know, a question maybe, so how do you feel most of the time? You know, would you say you feel happy? Do you ever feel down or sad? Or do you ever feel anxious? People with the diabetes have a high correlation of dealing with anxiety because of the blood sugar fluctuations. And then the depression could be the hopelessness and feeling just disempowered and down. So again, those kind of questions are very generic and open, but then if they said, yeah, I am feeling down. Well, tell me, how do you experience that? What is that like for you? Now, some people say, well, you don't know what it feels like to feel down? And the way to counter that would be, well, I can understand what it might feel like for me, but I always want to get to know what it's like for the people I'm working with. So tell me, what is that like for you? It can also be if someone does come in and you're helping them with some aspect of their medical issues with hypnosis on targets of better self-care, sleep, dealing with anxiety, dealing with mood, changing sensations, creating more comfort, pain issues. It can even be helping them to change and see the meaning they've given to it in a way that helps them feel more powered, like they can live and have a good quality of life with this. I worked with someone years and years ago, as we get into talking more about MS. The woman had MS, and with the MS, she had been very robust, athletic, and professionally competent, but with the MS, she felt broken and damaged. So what was happening is she stopped dating, and she desperately wanted to not be alone. And it really came out of the feeling of being damaged because of MS. Like, who's going to want me? And what happens if it gets worse? Then I'm going to be dependent. Who would want to be with someone they had to be dependent on? You know, that person was dependent on them. So we made use of hypnosis to help to be able to see that there was hope she could take care of herself. And she did a marvelous job making use of meditation and different thinkings, and she was very resourceful in how she was making sure to take her injections and seeing her doctors. And so we made use of the hypnosis, which really healed the brokenness. She started dating, and she ended up getting married, and she still had MS. One of the biggest issues was her telling her new partner that she had MS. And we made use of the hypnosis to create that comfort and confidence, that she could still feel worthy as she had conversations. As it turned out, what she didn't know was that her new husband that someone in his family had MS. And so all of the worry that had become totally conflated and so large, it was like, wow. So I'm not unworthy, broken, and unlovable. And I think this helping to understand more about diagnosis can also help to be flexible in helping the person to see where you can help them create some relief. Also, people dealing with a host of different diagnoses medical and mental health related, deal with a lot of tension, a lot of anxiety. And so when we teach people how to relax, making use of self-hypnosis, it is huge. And of course, there's a relationship now between the immune system and being able to relax, so that we can also empower their immune system, and empowering them by relaxing. The more you relax, the stronger your immune system is. The stronger your immune system is, the better you feel. And the better you feel, how wonderful it is to know you can live every day to your fullest. Wow, a lot of embedded commands that can help people to see there is hope here, living with anything. So the origins of the DSM, it's, believe it or not, the DSM, the Diagnostic Statistical Manual, did not start out as a helping book. It was a census. So basically 1840, and some of these terms that we're going to go through are going to make you chuckle and go, oh my gosh. It's because even some of the nomenclature here is indicative of the times. And so what's happened over time is that the labels change. And sometimes because anytime people have some issue that makes them feel diminished, then what ends up happening, the label conveys a pejorative sense about them. And I think people then own that as I'm broken, I'm damaged, and so forth. So 1840, the first official attempt to gather information about mental health. And they first were, interesting enough, back then, some of the main concerns had to do with intellect. So they would call it idiocy. And then also being, if people were psychotic or schizophrenic, that would be insanity. So this actually came out of a census. In 1844, the American Psychiatric Association started to look at different types of patients being cared for in hospitals. And so what they found is they started to look at the frequency of how often some of these diagnoses were assigned, like idiocy and insanity. Again, and it also was connected with census data. By the 1880s, we started to see labels coming out about different kinds of mental health issues like mania, melancholia, depression, monomania, paresis, dementia, dipsomania, epilepsy. These all were variations of terms that also captured how people looked at people that were quote unquote crazy, because that's basically what they were looking at back then. Interesting enough, if we do a little time travel, up to the 1960s, 1970s, there was a famous book by a fellow named Thomas Szasz called The Myth of Mental Illness. It's when we started to finally look at the fact that the labels themselves create the problems. And so the idea that we're dealing with a lot of mythic thinking when we also start to look at some of these mental health diagnoses. By the 1917 was actually World War I. What we were seeing is that there was a lot more interest in looking at wellness as a whole because there was a war going on. Interesting, 1918 is when that flu pandemic came out 100 years ago, inaccurately called the Spanish flu, but it was deadly. And so around this time, again, they wanted to start to look at coming up with a nomenclature. How can we understand different types of mental health issues, and can we give it some labels that give us some meaning? They continued even through the 20s to move forward with looking at, can we come up with some understanding so that we're not just looking at mythic thinking about illness, and it's not just a social construct. By the time we got to the 1940s, of course, World War II, and anytime there's a war, a lot of energy goes into evaluation, testing, on behalf of taking care of this large body of people that need to be service to help them. And so it was around this time that the World Health Organization started to come up with their own nomenclature, and it was basically the International Classification of Diseases, the ICD, and they're up to basically 9 or 10 right now. And so they basically came up back then with 10 categories that were descriptive of psychosis, which means when somebody is either having visual or auditory hallucinations or a thought disorder of some kind. Neuroses was actually an old term that came out of the Freudian psychoanalytic era that basically had to do with unconscious conflicts. Freud basically was pretty novel, and some of his teachings still have some value today, but I will say that when he came about, it was really a paradigm shift, because up until that point, they didn't look at what was happening for people in understanding the mind. So he broke it down into what we call the typology of the id, ego, and superego, meaning, and we still make use of the subconscious or unconscious mind. That is very much part of what we're working with as hypnotherapists. And so even if you think about it, 100 years later, we're still making use of some of these concepts. I will tell you that psychodynamic theory, while it's still being used, carried a lot of mythic thinking, was very misogynistic toward women, and also really basically assumed that the therapist was helping someone who was damaged. That is what came out of the original psychodynamic psychoanalytic thought. It has reframed over the years, and it's still being taught in clinical programs. It's more of a technique. There are people that do become psychoanalysts. Actually, who was the fella that did Woody Allen in the movie Sleeper? And he's in the story, he becomes, he's, I think, a technician working in a cryogenic lab, and he ends up accidentally going to take a nap in a cryogenic tube. And for some reason or other, the tube gets lost and it gets reopened 200 years later. So he wakes up in the future. That's the name of the movie. That's the theme of the movie. And his first thing when he wakes up and he's telling someone, wow, I was a technician, a janitor, I worked in a lab, and gosh, that was 200 years ago. You know, if I would have stayed in psychoanalysis, I'd almost be cured. So as we moved into the 50s, the DSM-1 first came out, which was the Diagnostic and Statistical Manual first edition. It was a glossary of different descriptions. They used the term reaction, meaning it was somebody's experience was a reaction to something, whether it was, back then they didn't really look at trauma, but that's what they were really speaking to. And it was a psychobiological view, and it looked at personality, psychological, social factors. And again, because probably up through from the 20s to the 50s, psychoanalytic thinking, psychodynamic thought was very powerful. The next wave was actually behaviorism. There was a fellow named Skinner who actually worked with pigeons and fed them, and came, before that there was classical conditioning with Pavlov, ring a bell? And so then from there we moved into humanistic psychology. So in the DSM-1, very psychodynamic,